Aaron Fox, Los Angeles LGBT Center. Madam Chair and Senators, we are in favor of the California HIV Alliance proposals. I'd just like to highlight two, which is item number 33, to eliminate cost sharing within the ADAP program. I was pleased to hear that the LAO actually said that eliminating this cost sharing would actually save the program money. So we think that's not only a win for consumers who have HIV, but also for the state. And on item number 35, we think that expanding the OA HIP program to all eligible Californians living with HIV would create equity within the program and wouldn't require general fund. We could get this done through special fund, and we would have more people without barriers to getting to care. In addition, the Los Angeles LGBT Center supports items number 3, 4, 7, 9, 10, 14, 22, 23, 31, and 36. Thank you.
Good afternoon, Ann Donnelly with Project Inform. We are also in support of all the California HIV Alliance proposals and the CalHEP proposals. I'm here to talk about proposal number 1, the Interagency Task Force to address HIV, hepatitis C, sexually transmitted diseases, and the opioid epidemic with a focus on drug user health. The reason that we think it's really important to look at these conditions together is because these conditions are syndemic, so they're interrelated, and they also synergistically create a greater burden of disease in already vulnerable communities. As you know, these health conditions disproportionately affect communities of color, men who have sex with men, low-income Californians, transgendered people, youth, people who use injection drugs, and those who are currently and formerly incarcerated. So the other reason that we think this is really important is we know that we have very effective interventions to actually end or eliminate these conditions and to also dramatically improve both individual health and population health in vulnerable communities. So California has done a great job in expanding coverage, and we're really grateful for that, to the legislature's role in that. It's helped many of the people who we serve. Where we've done a less than adequate job is integrating and leveraging the public health efforts that are necessary to enhance primary care and also focus on corrections health and the transition of individuals from incarceration into the community. In order to do that and meet our goals, we really feel that there needs to be a much higher level of both strategy and collaboration across Department of Health Services, Department of Public Health, CDCR, and Covered California. So coordinating those public health efforts with the primary care, we believe, is really essential to achieving optimum individual and population health outcomes. And I wanted to leave you with one concrete example of how this doesn't necessarily cost more money at all. It's leveraging existing resources and can make a dramatic difference. In New York, through a recent collaboratory effort between their Medicaid program and their state health department, they found 6,000 HIV-positive people in their Medicaid program currently who are receiving no antiretroviral treatment at all. And they were able to correct this. So it's a pretty dramatic difference just through a collaborative effort. So thank you very much. In addition, Project Inform supports items number 3, 4, 5, 7, 11, 14, and 22, and I only subjected you to half of them because my colleague behind me is going to give you the other half. Thank you very much.
Good afternoon, Craig Pulsper from AIDS Project Los Angeles, here to speak on 2 proposals from the California HIV Alliance. So the first is item number 34, the PrEP Financial Assistance Program. As you know, PrEP, or pre-exposure prophylaxis, is a highly effective HIV prevention intervention. Unfortunately, uptake has been slow among communities at risk. A recent study from the California HIV/AIDS Research Program found that only 1 in 10 gay and bisexual men were taking PrEP. The CDC recommends, or now estimates, that 1 in 4 gay and bisexual men are good candidates for PrEP. So I want to thank the legislature for allocating $2.2 million last year for a PrEP navigation program. This has been a huge help to help improve access to PrEP, but we're now seeing that cost is a barrier as well. So the medication is covered well by Medi-Cal and private insurance plans, However, individuals accessing PrEP must also see their doctor on a quarterly basis, so the copays for labs and those doctor visits can be cost prohibitive for uninsured and underinsured folks. So we're proposing a financial assistance program to cover these clinical out-of-pocket costs and any remaining medication costs for those under 500% FPL. And we believe the navigation program combined with this financial assistance program will greatly improve access to PrEP. And I just want to note that this, we believe, can be paid for with ADAP supplemental rebate funds and will not require a state general fund. The last item I'll speak to is item number 11, increased funding for the AIDS waiver program. This is one of 8 home and community-based services waiver programs in the state. So this provides in-home care to some of the most fragile people living with HIV, helps them avoid more costly institutional care. The program is extremely cost-effective. A study at AIDS Project Los Angeles found a decrease in inpatient days of 74% before folks entered the program compared to after. Unfortunately, the program is significantly underfunded, so rates for the program, most rates haven't been increased since 2001. DHCS found that rates in the program are 10 to 58% lower than other waiver programs for the same services. And this is also severely impacting access to the program. So in 2008, there were 44 agencies operating the program in 52 counties, and we now have roughly 24 agencies in less than 20 counties. So the proposal is $4.8 million to achieve parity with other home and community-based services waiver programs. And then AIDS Project Los Angeles also supports the other proposals from the California HIV Alliance, numbers 1, 33, and 35, the proposals from the California Hepatitis Alliance, number 24, and AIDS Healthcare Foundation's STD proposal, number 22. Thank you.
Hello, my name is Allison Harkey. I'm a social work case manager in a Medi-Cal AIDS waiver program in San Francisco, and we are the only waiver program currently operating within the county and able to provide care to the high level of need that the clients have within San Francisco. For this population, we're able to provide psychosocial education, medical education. A lot of these folks have a lot of co-occurring disorders, as was previously mentioned, and need a lot of the support in the community to access different resources and funds, and we're able to do that due to the nature of the program and meet them in the community, in their homes, and provide this vital care for them. However, due to the funding, obviously in our agency, we're not able to keep consistent case managers, and so the continuity of care for the clients does go down every time we have to transition and turn over staff and retrain new case managers. And I'm sorry, I forgot to mention this is obviously about the proposal number 11. Thank you very much.
Hi, my name is Melinda Adams, and I'm also with Westside's AIDS Case Management Group in San Francisco. And it's important for the case management aspect of our department and beyond, because a lot of our clients have severe fatigue and cognitive dementia and a myriad of other complex issues. It makes it very hard for them to navigate through the social services that help them get health care, housing, nutritional services, and other things that just help with their basic living needs. And so with what we provide helps them get through all this, and so they can continue to be healthy and living in the community where their care and they're living where their care in the community is. So that's why I'm here in favor of number 11. Thank you.
Good afternoon. My name is Kenneth Williams, psychotherapist intern with Westside Community Services. Those are my 2 former colleagues. As they said, we work in the AIDS Case Management Program. You know, there's a direct link for housing and health, and there are some of our clients that are housed, which is great, and it is quite a bit to help them get to their medical appointments. We have lots of people with multiple and severe psychological, emotional, medical, and dental health issues. So those who are housed, it's really great, and it eases the burden on them. But those who are not housed or marginally housed, it takes a lot of effort for us to find them, to get them to their appointments, to keep their appointments, and to increase their quality of health. And hopefully with the increase that is proposed for number 11, we can give them some of the same basic needs that we get, like food, housing, and safe housing. Thank you.
Good afternoon, Senators. My name is Emily Hirio from Project Inform and the California Hepatitis Alliance. CalHep is a coalition of 90 organizations around the state working to end hepatitis B and C. And we thank you for considering item 24, and also for your support last year for syringe exchange supplies and hepatitis C linkage to care demonstration projects. Just for some background to viral hepatitis in the state, the CDPH estimates that there are 350,000 Californians living with hepatitis B and 750,000 living with hepatitis C, and most of these people don't know their status. Hepatitis B disproportionately affects Asian and Pacific Islander communities, gay and bisexual men, people living with HIV, and anyone who's ever injected drugs, as well as sex partners of people living with hepatitis B. And the CDC recommends vaccination for all at-risk adults. Hepatitis C kills more Americans than any of the other 60 nationally reportable infectious diseases, and kills more than all 60 of them combined. In 2011, there were over 33,000 newly reported cases of Hep C in California, and low-income communities, African Americans, Latinos, and Native Americans are disproportionately impacted by hepatitis C. And as we know, syringe sharing is the leading cause of new transmissions and remains the second most common cause of HIV transmissions as well in the state. The unchecked spread of viral hepatitis threatens our state's economic and welfare and health. And untreated hepatitis B and C cause, among other conditions, cirrhosis, hepatic coma, liver cancer, and death. They're the leading indications for liver transplant and a major cause of hospitalizations in California. And we really believe with a small investment in prevention and care of Hep B and C, we can stop the spread of these viruses, save tax resources, reduce healthcare spending, and prevent needless suffering for California families. I also just want to back up my coworker, Anne, who noted some of the other proposals that we wholeheartedly support. 23, 31, 27, 33, 34, and 35, because of our similar populations of concerns and issues that are related to viral hepatitis. Thank you very much.
Madam Chairwoman Mitchell and members of the committee, my name is Richard Zaldivar. I'm the Executive Director and the founder of the Wall Las Memorias Project, and I'm here to support item number 24. Back in 1990, I had a dream to build an AIDS monument to people who passed away from AIDS. An AIDS monument to create for a place where family members could come and gather and remember their loved ones. But it was more a focal point to address the whole issue of stigma and bigotry and awareness about HIV/AIDS. And thanks to the support of former State Assembly Member Gil Cedillo and the state legislature, we built that first and only publicly funded monument in 1993. My dream for a monument was motivated by my best friend who shared with me that one day in 1989 that he was HIV positive. The irony was about 5 years ago, he passed away from hepatitis C. This was a construction worker earning $60,000 a year, but he always wanted a tattoo, and he got a tattoo, and he shortly passed away from that. We know that in people of color communities, whether we're in Los Angeles or in rural areas, communities, people are not aware of hepatitis C. And the economics and education underutilization of healthcare systems are a major issue in our communities. I ask you today to make an investment and support this measure. This investment will save the state millions of dollars in the generations to come. But more important of all, it'll be your will, your leadership to say in California, we're going to take a position on hepatitis. Because at the end of the day, I don't want to be part of a community where we actually have to build a monument to people who passed away from hepatitis. Thank you for your support and your leadership.
Hello, my name is Rick Nash. I'm a Hep C advocate, and I'm here in support of number 24. I was diagnosed when I was 13, and my mom was found to be the source. And she went through all the different regimens of treatments, and this was all throughout my high school. And then when I turned 21, I took my first treatment, and it failed. That was the interferon ribavirin. And then a year later, I took it again, and it also failed. 2 years later, it came out with the triple cocktail. In Civic was the third drug that was added to the root regimen. My mom tried it, and she was cured. She went through 4 blood transfusions to make it through there, but she managed to push through. I wasn't as lucky. At 3 months, I had an esophageal bleed, so one of the veins in my throat burst, and I vomited out blood in like 2 units in like a minute. And it just got progressively worse over the next few years as my liver disease progressed. I then went on the transplant list about 4 years ago so that I could do Sovaldi Alisio in 2014, which also failed. But interestingly enough, I was able to zero out. I was able to clear the virus completely for a period of time, but it's not cured until it SVRs. So, sorry. I forgot where I was. So when the fourth treatment failed, I was kind of devastated because my whole family was I had never seen my dad like so excited in my entire life, and it was a real like amazing moment for me. About a month after the fourth treatment failed, I turned completely yellow, like Simpsons color yellow. It was ridiculous. And then I went on to Harvoni because Sovaldi Alisio had failed. And I jumped through all 24 weeks of that, and it zeroed out halfway through. And I was stoked, but this time a little more cautious just because of what had happened previously. And it failed last year. And so this year I've been looking at the newer treatments and whatnot, but I'm here advocating for proper testing because, like, the reason how I found out was purely coincidental. And, like, it was a hot day and I hadn't had enough water to drink, and I peed an unusual color, and it was brown. And we checked it out, and that's how we found out everything else. And if it weren't for that, I could have been going through the next 5-6 years, like, doing irreparable harm to my liver without even knowing. So, yeah. Sorry. Thank you.
Chair and members, Kathy Mossberg representing the San Francisco AIDS Foundation. I think that I'll just sum up on the number of proposals as it relates to the HIV Alliance proposals as well as the CalHEP proposals. As you've heard, there are a lot of these things that can be avoided through prevention for sure, and a lot of cost savings that can happen through prevention with these programs, and certainly getting people into better testing and treatment. So all of these are proposals to move towards that direction and to bolster those systems. So we encourage your support when the time comes for a vote. Thank you.
Good afternoon, Glenn Backus for Drug Policy Alliance. I'll be brief in support of the request for a grants program for naloxone distribution to those at highest risk of witnessing or experiencing a drug overdose. As you know, drug overdose is the #1 cause of accidental death in the state. More people die every day of drug OD than die in car crashes in California. That includes people who are hit by cars as pedestrians, the #1 cause of accidental death. We're asking for a very modest $3 million investment in reducing the number of deaths. The investment we've made in prevention and treatment has been inadequate to curb this epidemic. Witness the 400% increase in the number of deaths in the last 20 years. Seeing as it's a small amount of money, it has to be very cost effective how we spend it. So we focused on the most at-risk population. According to studies by the Annals of Internal Medicine, British Medical Journal, CDC, We need to focus on those who are most likely to be there when an OD happens, and that's drug users themselves. Coming out of jail, in treatment or coming out of treatment, or attending needle exchanges, if we focus on those programs and those settings, we can get training and naloxone into the hands of those most likely to save a life. The models in the city and county of San Francisco, in the states of New York and Massachusetts, provide us a model for effective implementation of this policy that will reduce spending, reduce suffering, and reduce the number of family funerals next year. Thank you.
Good afternoon, Madam Chair and members. Heather Harrison with the California Assisted Living Association, here speaking on two issues. The first is item number 2, the Cal Quality Care website. We are opposed to using licensing fees to fund this website. The state currently maintains a website, a consumer site for residential care facilities for the elderly. It's very comprehensive, and it's funded in part by licensing fees, so we're concerned that this proposal will be duplicative. I also want to speak to item 26, early detection and diagnosis of Alzheimer's disease. We are in support of the one-time request. Early detection and diagnosis can lead to early treatment, and I think that's something we're all looking for these days. Thank you.
Good afternoon, Madam Chair, members. My name is Carol D'Elia. I'm Executive Director of the Little Hoover Commission. I'm here not speaking necessarily to any items, but I wanted to thank Senator Stone for his comments on Deni-Cal. Last month, we came out with the report recommendations fixing Deni-Cal, and I will be very brief. I'll be happy to discuss in a different setting the details of the report, but basically we found a system that was dysfunctional and full of unnecessary bureaucratic red tape, but we also found that the reimbursement rates from the dentist's perspective were very low. We're some of the lowest in the nation. It's 1/3 of commercial. As a result, a lot of dentists don't take Deni-Cal. So we have 5 million children in California, half of our children in California are part of the program, and many of them, as you heard earlier, half of them didn't see a dentist in the most recent year. We'll have additional children joining the ranks next week, and they too won't be able to find a dentist. So we wind up instead with children waiting. They can't go to the dentist. We spend 86% of our Deni-Cal money on restorative work as opposed to preventive work. So our report highlights putting prevention first. We made recommendations as far as reducing some of the red tape. We also support item 20, teledentistry. That was one of the recommendations. But mostly I'm here to say that we support the proposal to raise reimbursement rates for dentists to do preventive dental care. So thank you.